I work as what's called a neuropsychiatrist, so a little bit neurology, a little bit psychiatry, but mainly I'm interested in behaviour, mood, anxiety, that sort of thing in Huntington's disease. And that's what I'm going to talk to you about today. I would say some of these topics are quite sensitive and difficult because they're about emotions, and emotions are hard, aren't they? They're really tricky things, and families and husbands and wives and all that sort of thing. So that's just a sort of little, in the modern day, you'd probably call it a trigger warning, wouldn't you? It's a trigger warning to say we will be talking about probably some difficult emotional stuff. So I'm just letting you know that now. Not terrible, terrible emotional stuff, but emotional stuff. Right. So can everybody see underneath that little conversation there? It says, Doc, so how are things? And this is the patient comes in with the spouse. So the patient sits here, and then the spouse usually sits next to them, but a little bit behind them. So the patient's front and centre. So I say to the patient, how are you, sir or madam? And they say, that's Birmingham. I'm all right, Bab. That's Birmingham for I'm fine, because that's where I'm from, because we'd like to call each other Bab. And then the spouse who's sitting behind starts crying or looking like it's really not fine at all. But the patient's going, yeah, it's fine, everything's fine. The spouse is going, it's not fine. And also maybe crying a bit. And that happens so often in my clinic, I can't begin to tell you how common it is as a problem. And it made me think, I wonder what's behind that, because it's such a common thing I see in that clinic, much more than any other clinic I've ever done. And I think if we understand that, then it helps us to understand all sorts of things that are going on in Huntington's disease. Okay, so what am I going to talk about? So a little bit of biology, but not very much, just so that we know enough that we can make sense of emotions and things. And we're going to talk about a bit of the brain that gets affected in Huntington's disease called the striatum and what it does. We're not going to spend a long time at it, just enough so you can understand what it does to help you understand when it goes wrong, how that might affect someone emotionally. And then we're going to talk about the main things we're going to talk about: depression, anxiety, irritability, and what I call social cognitive problems. That's a bit like, I suppose, in the modern world, we might say autistic spectrum sort of behaviours, but within Huntington's disease, finding it difficult to understand social rules or social interactions, and act in a complicated social way. So those are the main things we're going to talk about. So the biology, actually the first slide I was going to show you about the genetics of Huntington's disease, but I think Liz already told you that. Just very quickly, that little pink and red line along there. Oh, I haven't got a pointer, have I? Or is this a pointer? No, it's not a pointer. Okay. That little red line there, red and pink line. Oh, I've got a pointer here. Look at that. Pen, laser pointer. That's the Huntington, that's a whole Huntington gene. And that little bit of it at the beginning just gets expanded. And that makes a little bit of extra long bit of the protein, which makes it fold in a slightly different way, but not very, very different. And that's happening since you were conceived if you've got a positive test. So that starts from the very get-go. It might even be at the beginning, that slightly changed protein actually might be a benefit to some people for early brain development. But as time goes on, that protein accumulates and it causes problems. It's really important to know that this starts from conception, because it makes you, I think a lot of people say, oh, you're just fine, and then one day in your 40s or something happens and it starts. I suppose we've always sort of grown up with that idea, but I want to get you in a different mindset, which is to say, this protein, this unusual protein, is something that people with HD have always had in their brains, and it does some good things and some bad things over the whole of the lifespan. So it's a very different way of looking at it, but it can also help you to make sense of perhaps early changes or shifts in behaviour or mood before a person's obviously affected. Now, there's all sorts of things that affect your behaviour and mood all the time. My behaviour and mood isn't stable the whole time. I don't carry the HD gene, but I can be grumpy, moody, anxious, angry sometimes, sad. So I guess that's an important thing, is if you have a person with HD who is grumpy, moody, anxious, sad, getting a bee in their bonnet, or going on about something for ages and ages, that's not always an HD thing, because I do all of those things and everybody probably does them all. It's just which bits are to do with HD and which bits are to do with just trying to get on with normal life. Okay, little bit more biology, not much. It's just a brain, really. This is a brain. This is a brain from the front. It's a big brain slice. Of course, to make a brain slice from a human, it has to be a dead human, obviously, because we can't, that's a real brain tissue there. And on this side, this is the brain of a person without HD. And I just want you to look at this bit here, that little sort of egg-shaped thing, that's called the striatum. That's the bit of the brain that really gets hit in HD. This is a person with very, very severe HD, like the severest you could possibly imagine, who's died of that condition. And this is their brain. You can see that bit of the brain particularly has really sort of disappeared quite a lot. But the rest of the brain is also somewhat affected. Can you all see that? Okay, good, just checking. And then I want to just show you that this is the last sciencey bit, I promise. Not too much science. I want to show you a little study which looked at some brains of people. That bit of brain I was telling you about, this is a look at the brain from the side. So imagine if you've got a big axe and you chop my brain like that, and you looked at it from the side, you can see all the brain bits there. That's called the sagittal section, but that's what that is. So that's the front bit where, if you imagine the nose would be there, the back of the brain is there, that little knobble on the back of your skull is there, and that's the top. That's the same bit of brain just tucked in there. And this is a nice image from somebody, just to show you that bit of brain changing over about 3 years. So it's like a watch this space. So look at that little bit of brain there. Everybody got that slightly darker grey bit? And I'm going to go baseline, 1 year, 2 year. Can you see that bit sort of shrinking down a bit over the time? Probably more than the other bits. So go back to that's baseline, 1 year, 2 year. So that's the bit the HD seems to target. And so we want to know, what does that bit do? So if we know what that bit does, it might help us understand symptoms and that. Okay. Well, it does some amazing things, actually. That's the same bit of brain, just on its own. And it's called the striatum. And to know what the striatum does, you've got to understand, why do human beings and or other animals move? So do you know why we move? Anybody got any bright ideas about why we as animals, human animals, why do we move? What's the point of moving? There's only 2 points. Okay, fair enough. So any other reasons why we might move? To go for food, to find food, yes, good. So we move towards things which might benefit us. So by the same token, what's the other reason we might move? To get away from danger. So humans and other animals, we evolved to move for only 2 reasons, really. To get away from bad things and to get towards nice things. And, if you couldn't move, then you'd probably struggle with both of those things and you wouldn't last very long and you wouldn't be able to pass your genes on. And this bit of brain is involved with coordinating all the information to decide on those things that we do. Does that make sense? Yeah, so interestingly, it has lots of inputs from things like, there's a bit of brain called the amygdala, which is like, danger, danger, avoid, avoid. So that's inputting into there. There's another bit of the brain called the ventral striatum, which is like, that looks nice, that's a possible opportunity. Food, mating, warmth, all those things. So that's inputting in there. There's another bit that comes from all the body going, this bit hurts, that might be a problem, that might need fixing, that all goes in there too. And there's another bit which is like, okay, we need to move in that particular way. How are we going to plan to do it? How can we have a strategy? So in other words, if I want to go and get some blackberries or something, like my brain has got to make a plan for doing that. So all that stuff is in there too. So you've got all that initial data, like what do I want to do to get away from something towards something? How am I going to do it to make that work? How am I going to follow it to make sure it's finished, completed the goal? And this bit that I put in limbic, that means it's joined up to that's really bit that controls mood and emotion. So that plays in to that whole what are we going to do? Because as you know, when your moods change, your motivation to move around and to do things changes. So if you imagine all that information to say, what are we going to do next? This bit of brain is the grand central station for all of that information. So what I want you to do is try and imagine, if we're saying that's the bit of the brain that Huntington's mainly targets, try and imagine how that might play out in a person's everyday life, in the things that they do every day. And there's a million ways in which that might play out. But that's to me, that makes sense of what I see in the clinic every day. So, right, we're going to get on to symptoms now, but you can keep that little bit of anatomy in your brain if you can. So, there are three sorts of groups of symptoms, and loads of people have shown this. We were just one of them about 15 years ago. There's one group of symptoms, which is the one at the top. We've called irritability, apathy, poor planning, and perseveration. So perseveration means getting a bee in your bonnet and going on about the same thing over and over and over again, long after everybody stopped talking about it, or doing the same thing over and over again, long after everybody stopped doing it. These things mainly seem to very much relate to the illness itself. In other words, people who get ill with the illness tend to get those things a bit more, possibly with the exception of irritability, which sort of varies a bit. The next group of ones is depression and anxiety. Those things are really common in HD, but actually they are in the world too. So if you were to take a husband and wife, one had HD and one didn't, it's probably a little bit more likely that the spouse would be depressed than the person with HD. A little bit. So we're talking about very common things, and if you track the depression and anxiety through the course of HD, it doesn't really track with the illness. You get a bit here and a bit there. It comes and it goes, and it may be there for a little while and then gone. And, it's quite common when people are first diagnosed or first get a genetic test, or people with HD suffer a lot of losses, don't they? Maybe the work or the driving or other things, and these can be triggers to depression and anxiety. So with depression and anxiety, it doesn't gradually get worse as the illness gets worse. It comes and goes at different times for all sorts of reasons, which we will talk about. There's a small group of people with HD who get psychosis. That's things like hallucinations and delusions. But it's not a very big group, and we don't know much about them because they're not a group of people who necessarily are usually open to being studied in detail, because they might be in a psychiatric care or something, so they might not particularly want to be studied. So we can say there's a group of people like that who we don't know much about, but it's not a big group, I don't think. So it's really the first two that are the big deals, the irritability, apathy, poor planning, perseveration group, and the depression, anxiety group. And they seem to be sort of separate sorts of things. So we're going to talk about depression because depression is common. Right. And in order to understand depression, we've got to understand a couple of things. A big thing is depression is different to apathy. And apathy is quite common in HD, but it can look like depression. So in other words, I'll meet, it's usually a husband and wife, they come into clinic, and one of them will say, he or she is terribly, terribly depressed, doctor. And I say, what makes you say they're terribly, terribly depressed? They say, well, he or she sits on the sofa all day watching the same program over and over again and is not really very talkative, not very interactive, and their face looks a little bit blank. So they must be awfully depressed. And then you say to the patient, you say, oh, how are you, sir, madam? And the patient goes, oh, I'm fine. I said, you're sitting watching the telly all day long and you don't seem to be interacting at all. And they're like, yeah. How are you feeling? Oh, fine. What are you thinking about? Oh, not much, really. And so it's something on the surface. If you saw someone like that, your natural instinct would be say, that person's really depressed. Because they really look at everything we imagine for depression. But if you talk to them about what their internal mood state is, they might say they're fine. And it might genuinely be that the people with HD may not some people at a certain stage may not have a lot of the sorts of thoughts that, for instance, I would have a lot of. I'm going to give you for an example. It's a Saturday. If I was at home, probably this time of day, I would think I'll probably have a bit of a sit down and read the paper. Because, I'm partly retired and kids are grown up. Sit down and read the paper. I can guarantee you I'll sit down with the paper, and after about 30 seconds, something will pop into my mind about something that needs doing or something that needs planning for the future. I'll think, I've got to do this, I've got to do that, and I mustn't forget to talk to so-and-so. And there's a whole load of things that come into my head. I mean, am I alone in that? I don't know. There's a lot of people have that thing. And I think some people with HD stop doing that to the same extent. Stop thinking a lot about the future. They can get quite in the present moment, actually. Just, this is comfy. And maybe after a while I'm a bit hungry or I need a bathroom or something. But, they quite commonly don't have that, after a while anyway, that constant chatter of this might happen, this might happen, this might happen, I need to do this, I need to plan for that. So you could say for a person with HD, that can actually be quite a relief. It enables you to sit down and watch reruns of, Accident and Emergency Special on Dave TV or whatever it's called now. But it's hard for a partner to deal with that, I think. Okay, so we're going to talk, that's one bit about the depression thing. It could be apathy, not depression. The other way of finding out, there's a wonderful phrase, which is anhedonia. Anhedonia means the inability to take pleasure in a very everyday thing. So I've already had many pleasures today. And I'll give you an example of a pleasure I had today. I already told you I had a nice fry up this morning. That was very pleasurable. Nice fried bread, lovely. Good toast, good tea. I had a cup of tea in bed myself about 7:30 this morning with that little kettle thing you have in the room. And that was lovely. So I just sat in the bed, had a cup of tea. You know that feeling? It's not an intense pleasure, is it? But it's a pleasure, nonetheless. And when people are asking about whether you experience pleasure in the everyday, we're not talking about the day I went to the big theme park or the big whistles and bells party. We're talking about the pleasure you might get of seeing an old friend. Like I saw Ashley. Where's Ashley? I saw Ashley earlier on today, and we had a nice hug because we shared stories from the past. And that was just a nice feeling. It wasn't intense. It was just a nice bit of pleasure. How are you doing? Not seen you for 5 years or whatever it was. So depression really is the inability to have those things, that everyday, very low level pleasure. And that's the sort of thing you've got to check with people. So I think if you didn't get any of that everyday low level pressure for maybe low level pleasure for maybe a couple of weeks to a month, that's actually quite unusual. I think that's what might you think of depression. That lack of the inability to experience normal everyday pleasure. So I think of myself, my mood varies through the day, and yours probably does too. You'll have times in the day when you're quite anxious. You'll have times in the day when you're fine. But then imagine if you had that not getting any pleasure, feeling low in mood, pretty much all day, every day for a fortnight, that puts you in the clinical territory. That's when you start thinking about depression. There are a bunch of other symptoms of depression that we talk about I'm a psychiatrist primarily. We talk about things like not sleeping well, having a low sex drive, not being able to concentrate, losing weight, lacking in energy. Now, those aren't very good in HD because people with HD can get all of those symptoms without being depressed. They can get changes in appetite, changes in weight, changes in sleep, changes in concentration, changes in energy levels. They might not be depressed at all. So it's not very useful for finding that out. Then, the other bit I want to talk about is sometimes if a person with HD is depressed, you might say, well, I don't know. You might sort of pass it off a bit and say, well, I'd be depressed if I was in that situation, wouldn't I? Therefore, it's sort of, it's just normal, so we're not going to do anything about it. I think there's a danger in that approach. I'm not surprised you're depressed, given all the things that have happened. I'd be careful about that approach because depression looks a little bit different to that. And I'll just try and illustrate that to you. HD is a neurodegenerative illness, so things get worse quite gradually. I mean, ridiculously gradually over decades, really. But if you did that, and then suddenly your mood changed, over maybe a week or two or a month or two from a totally different sort of level from what it'd normally be, that's a moment what you might think of depression. There might be some other things that might cause that, like some infections or pain or some other bits and pieces. But that's sort of drifting off what you'd normally think of the normal trajectory to be. So there's somebody who might have HD a year ago and is not depressed at all. They're still in the same circumstance, but then they've developed depression. You can't say, well, you're just fed up because of the HD thing, because they weren't fed up about exactly the same thing 6 months ago, if that makes sense. Okay, so there are all sorts of reasons why a person might psychologically be vulnerable to depression. I guess people with HD have more losses in their lives than the average person. And they usually come in a bit more of a concentrated way, whether that's jobs or relationships or driving or goodness knows what. There's a lot of losses that come with that, or other family members. They also might be on some medications, and I guess that's the first thing I would think of. If you're looking after a person with HD, or you have HD yourself and you're experiencing depression, the first question you should be asking yourself is, what medications am I on already? And is there any sort of match-up between being started on a medicine and getting these symptoms? Because some medicines we use can cause or worsen depression. So I'll give you an example. It's not necessary to pick this drug out amongst many. There's a drug that's commonly used in HD called tetrabenazine, which is used to control movements of one kind or another, chorea mainly. And at a high enough dose, that would probably make everybody in this room quite low in mood and a bit amotivated. So if somebody comes to me and says, I've just been feeling really down over the last 3 months, first thing I do, reach for the meds chart and go, that's interesting, because you were just started on a ton of tetrabenazine 3 months ago, and then within about 3 days, here comes the depression. So if someone with HD complains of depression, one of the first things you should really do, go back and look at the drug chart. Or if you're not used to looking at drug charts, talk to somebody who does, like a doctor. You can say, look, there's a match there, had that medication, a week later, started the depression. So which medications you're on is a big one. I mentioned something about early attachment problems. Now, I guess we think of depression outside of HD world. One of the causes of depression is possibly adverse early life experiences or problems with attachment in early life can be a risk factor to depression. And I guess if you're growing up in an HD family where your mum or your dad had HD, there's a chance there may have been some attachment problems at that stage. That's one of the sort of generational difficulties of HD. So we've got to think of that bit as well. There may have been some attachment issues early on which are feeding into depression. Gosh, that's a lot to think about, isn't it? I want to mention something briefly about suicide, because people with HD still do end their lives more often than you would expect in the general population. Not loads more, but certainly a little bit significantly more. And people in this room may know people who've taken their lives, and I've certainly had a few patients who have over the years. A couple of things I want to say about that. Firstly is it's okay to ask people. If you ask people about whether they're thinking of harming themselves or ending their lives, it's not going to make it any more likely. In fact, it might make it a bit less likely because there's something you could do about it. So don't ever feel that you couldn't ask a person because you feel like, well, if I ask them, I might put an idea in their head that wasn't there before, because I don't think there's any evidence for that. It's okay to ask people about it. And then to say there are certain risks periods for suicide in HD, and their main ones are round about genetic diagnosis time, and that's why I guess we have the genetic counselling business at that point, but also when a person starts to think a little bit more about becoming clinically affected, or they've had a bit of a problem at work and a bit of a bang in the car, and to them they're thinking, oh gosh, something's really happening here. And that's the point. That can be a risk period for people harming themselves or trying to end their lives in one way or another. Interestingly, I think, given all the things that people with HD have to deal with,
the life events and the way the brain is, I'm surprised more people with HD aren't more depressed more of the time. What strikes me is that actually, well, the thing I said, it's more often the spouse that's obviously depressed rather than the patient. The patients do get depressed too. And I think there's something about the nature of HD, partly it might be the ability of people to think about future scenarios, which is actually a little bit protective or helps people to get better from depression more quickly than the average person would. So, yeah, I'm just going to skip over that one. Right, so if we see a person with HD who does get depressed, and you might apply this to anxiety too to a certain extent, here's some of the ways we'd think about it. Firstly, we'd say, do you actually need those anti-chorea drugs? So you might be on drugs for chorea. That might be, I don't know, tetrabenazine, risperidone, clopixol, sulpiride, olanzapine. It's just like check those drugs and make sure sometimes that you can take those drugs, it won't have any effect on your mood at all, it'll be fine, and it'll just be tickety-boo. Sometimes you can take the drugs at certain doses, they might trigger depression. So that's the first thing I do is check the drug chart. Are they on any anti-chorea drugs that they might not need, that might be contributing? Are they stoppable? Good news is antidepressant treatments commonly work well, and that depression quite commonly resolves itself in HD, probably a little bit more common than in sort of general psychiatry world. So that's good. Antidepressants work well, time often works well. Social interventions. So there are things you can do socially which might help, because certain things might be making the depression worse. A classic example is too much going on. So cognitive overload can be something that perpetuates depression. I'm going to give you a little example of that, which anybody who's here yesterday will be bored of hearing, but here we go. I had a man that I looked after, and he's in his 40s, and he lived with his he lived with his wife and his 2 daughters in a smallish house in the Black Country in Birmingham. Any of you know the Black Country? It's where the Industrial Revolution started. Wolverhampton, Walsall, all around there. And anyway, he lived with his wife and his 2 daughters, who were all lovely, but quite over-involved. You know, they're always asking how he was, what's going on, how's he feeling, all that stuff. And he actually got quite down and a bit irritable. And his solution to that was to go and live down the road in a flat on his own. That's quite a radical solution, isn't it? Turned out it worked a treat. It worked really well, because his family were really caring, but he just couldn't process all the information they were putting in front of him all the time. So he lived in this flat on his own down the road. His wife and his daughters came to see him every day for 20 minutes each, and they got on really well. Everybody stayed together. It was fine. He was happy. They did a little bit of adapting, and they were happy. So I'm not saying everybody with Huntington should go and live in a flat on their own. I'm just saying that worked for them, because one of the things that was making the depression worse was just too much stuff, too much information all the time coming at them. I didn't advise him to do this. I would have probably advised the family just to tone things down a bit. He took his matters into his own hands and got his own flat. But when he did, it seemed to work. So there may be other things that have triggered depression, like I've seen. It wouldn't be an uncommon thing that a person had a swallowing problem. They were doing fine, then they choked on a fish finger, and then they went into a big depression after that. And you can sort of see why that might happen to a person. So it might be that managing that symptom, really good swallowing management, could be a really key thing to treating the depression, because you know that one event sort of triggered off a whole series of thoughts and feelings and emotions which put a person into depression. But if you can say, we recognize that, we're going to take steps to minimize the chance of that happening again, that was great. And then support for everybody, because depression, if you've got someone in the family with depression, which is not that uncommon, it does affect everybody, doesn't it? It affects everybody. And it's just getting me to touch onto this area, which is, I think, a very sensitive area. It's called ambiguous grief. Now, ambiguous grief is a form of grieving for somebody who hasn't died yet, but they've changed in who they are. And so you're not living with the same person, perhaps, that you did live with, even though they're still there. So if you imagine if you're the husband or wife of somebody who's changing in that way, and sometimes people will say, oh, it's not the person I married, it's not the same husband or wife that I first married, they've changed. And so that's a grieving process, isn't it, that you have to go through even though the person hasn't died, and that's why we call it ambiguous. But also, if you're the partner of somebody like that, it may also be that you go through the phases of grief while the person's still there. So that's all, the normal phases of grief: depression, reasoning, denial, anger, all those things we've read about. So as a partner of someone with HD, you can go through all that while the person's still there in the room, and that really can affect the psychology of what's going on. So you really need some looking after in that moment, really, and some understanding of that. Okay, I'm moving on from depression, and we're going to talk about irritability. So, hands up in the room, all those people who get irritable. What makes you irritable? What? Mad drivers. What else makes people irritable? What? Kids. It's cognitive overload again, isn't it? Too many things going on. I think cognitive overload makes me irritable. So if I'm trying to work on, I don't know, a paper or something, and then somebody knocks on my door and wants to complain about something, and then, if I'm at home, somebody rings on the doorbell, or I've got a pan on the stove, and there's too many things, I'm going to get snappy at that moment, especially if I haven't slept properly. So irritability is normal, but it can be excessive in HD in different situations. And that's just how I define irritability: excessive angry response to a minor stimulus. So in other words, it's like you say, we've all experienced that with people we know. You only said something very small to a person and they've bitten your head off in a second. It's like, oh, I only asked you if you wanted a cup of tea, sort of thing. And that's irritability. And it can be a feeling, but it can also be something that you do. Because sometimes if you're very well brung up, you can feel very, very irritable, but disguise it really well. But it still doesn't stop it from being irritability because it gets you. I guess what I want to say about irritability in the relation to HD is, firstly, it's really common. It's really common, and it's a bit common in spouses as well. But also, the thing you want to be careful of is to say, oh, it's part of Huntington's. Irritability is part of Huntington's disease. So we just think of it in that way. I would say, well, it is, but irritability has like 30 different causes in HD, all of which are different, which require different approaches. So I'm going to give you some examples of those causes. And those causes, or where you look, also depends on whether the person with HD can tell you what's pissing them off or they can't. Obviously, if they can, that makes it a lot easier. If they can't, because speaking is difficult for them, then you're going to have to be a real detective and imagine things. Okay, so here's some irritability causes. I put cognitive overload at the top there because that's a really common one, and it's something you can do something about quite easily by keeping things simple and learning not to overload a person and not expecting them to fully participate in things with a lot of cognitive input. But here's a whole bunch of other things, including some very physical things like constipation. Now, I'm lucky, I don't get constipated very often, but if I ever do, I am like a bear with a sore head. I'm not a good person to be around. So it's one of those things, like if you could speak to somebody, say, are you constipated? And they say, no, I'm not. That's a different thing. But if the person wasn't able to tell you that, you'd have to use your skills to work out whether it was true or not. Sometimes people are just grumpy, independent of Huntington's disease. And, we know in life, some people are more irritable than others, Huntington's or not. So some people are just a grumpy so-and-so, and that has to be factored in too. So I guess another one I'll just add into that, which again, people who can't tell you, can't localize things, might not be able to do very well, is toothache. So sometimes people with HD can have grumbling toothache. They can't tell you that's what it is. They might not be able to localize where it is. And, the tooth comes out and suddenly the irritability goes away. So that's one of those ones that I've seen once or twice. So take-home message is, someone with HD is irritable. Don't just say it's HD. Go through your list of things, see which of those things it might be. And most often than not, it's cognitive overload. So how do we manage this symptom? We treat the underlying cause. We've been through all those potential things. If it's hunger, then the treatment is food. If it's constipation, then the treatment is laxatives. If it's cognitive overload, we reduce the cognitive overload. So we've got to do that detective work first. But also manage the relatives and carers, because sometimes, you know, I talked to you a bit about this ambiguous grief thing. Sometimes it's the spouse that's triggering the irritability, because the spouse is basically getting really angry at the person with HD because they're not who they used to be. And so they're triggering the patient's irritability because they're dealing with their own grief. So I told you it's going to be a tough talk. That's quite a tough situation, isn't it? If you've done all that and there's still irritability there, then meds can be used as well. But I usually, let's hold the meds back till we've done some of these practical things. Okay, we're coming towards the home straight now. Remember this clinical scenario. Me going, how are things? Patient, fine, thanks, or I'm all right, Bab. And then the relative does this thing called the face palm, which is that. And I've just illustrated there, a little Star Trek illustration. That's Captain Jean-Luc Picard. And what's it say? When words fail to describe the dismay, there is always face palm. And I see those face palm in moments in clinic quite a lot, in different forms, when you say to the patient, how are you? And they're like, oh yeah, I'm fine. And then the husband or wife is, or they might cry or something. And the patient might look over at the husband and wife and look at them like, what's going on here? I don't really fully understand. And they might put their hand out and just touch the hand like, I'm not quite sure what to do in this situation. But I call it the double face palm because two things are going on. Here's the double face palm. When the fail is so strong, one face palm is not enough. The double face palm is when the patient says they're fine and the wife starts crying or the husband starts crying. First of all, number one, they're not fine. They've changed quite a lot. But number two, they don't really understand what the situation is they're in. They can't see. So they're in that situation. They go, I'm fine. The husband or wife starts crying and they're looking around going, I don't really understand this situation. I don't understand what's going on here. I can see there's some upset or something. So that's why I call it a double face palm. Not only are they not fine, they don't really know that they're not fine. And that's a big problem. And we're going to talk about some of the reasons behind that and what we might be able to do. There's this thing we call executive function. And it's something that bit of brain I was telling you about does. It's about planning and organizing your brain for things. And there's some very everyday things that our brain just takes care of. We don't even have to think about, but they're actually quite complicated things. So if you drive a car, let's take the car example. You drive a car. I can go on a journey of 100 miles in my car, and the whole time I've never thought about my clutch foot. The whole time. I've never thought about the accelerator or the brake, because my brain has gone, don't worry about that, Hugh, I got that all under control. Sorted. I'll only tell you if there's a problem. I don't even hear that message either, because it's just doing that stuff. And we don't even know it because it just happens. But imagine if you didn't have that, how difficult it would be that you'd have to think about every movement before you did it. But that's a bit that's impaired in HD, so that's an inability to multitask things, even things like driving, or the other one is the person could sit at a table in the peace and quiet and eat a meal fine. But if you say, okay, you've got to eat a meal sitting on your lap with a tray, watching repeats on Dave of something or an action movie, then there might be choking. So there's this reduction in the ability to multitask and plan ahead. So I'm going to take you to a typical situation. You're at home, you see you're with your husband or wife, and some relatives come around. Your Auntie Barbara comes around with the kids, and all you're going to do is you're going to have some tea, some scones, and some chatting. That is actually quite a difficult situation. It doesn't seem like much, does it? That's actually a hard situation. There's a lot to be thought about in that situation. There's who takes the turns in the conversation, what you're talking about. The kids are making noises over here, so you have to filter out stuff. There may be tensions within the family. That's really common in most families. There's all that. That's a lot of things to deal with. And so sometimes you might find in that situation that the person with, you look around after 10 minutes, the person with Huntington's disease, they've gone. They've gone into the bedroom. And they say, what's the matter with Brenda or whatever? No, oh, Brenda's just gone into the bedroom. And it looks really bad, doesn't it, on the surface of it? You're just having some people around for tea, and then somebody's just gone off and they're sitting in their bedroom. In most normal situations, you'd think, well, that's a bit off socially, wouldn't you? But in HD, you can see why that happens. It's just that thing of interacting with a lot of people together, taking turns, dipping in and out, filtering out other information. That's a hugely complicated job that we just take for granted every day, but people with HD would find difficult. Another thing people with HD can often find difficult is you say, we're doing thing A, and then at the last minute you say, oh no, sorry, we're going to do thing B instead. That requires quite a lot of thinking change, and people with HD find that very difficult. Or you might say, I'm popping out for half an hour, which is a turn of phrase. It doesn't actually mean half an hour, does it? Just popping out for half an hour. How long do you think, when you say I'm just popping out for half an hour, how long do you think that means, roughly? 2 or 3 hours, okay. I mean, I'd probably say up to an hour. I think if I say I'm going out for half an hour, I'd probably say up to an hour before I worry. If my wife said to me, I'm just popping out for half an hour, I'd only start thinking, oh, if it was an hour and a bit, I'd be like, oh, that's a bit odd. But so if you say I'm popping out for half an hour and you come back in 31 minutes, then somebody might give out at you with HD, like, well, you actually said half an hour. We get that, I get that in clinic. Well, they said, she said, I was popping out for half an hour, I came back just over half an hour, and he gave out to me like anything. And I'll say to the person with HD, well, what do you think about that? And the person with HD will commonly say to me, well, she said half an hour and it was 31 minutes, so I'm actually right. And I suppose that's this sort of slightly concrete way of looking at things, which again is this inability to be cognitively flexible and have a bit of flex. Well, that's a lot of things that we do. We don't even know we're doing them half the time, but people with HD find all that stuff difficult to do. There are some bonuses that the brains are quite plastic, so they find little workarounds for things, but not always. So when that bit goes wrong, what do people do? Well, they start getting anxious about going out. They start getting panicky. They start getting antsy and irritable. They might get low and they might withdraw, like the lady I was telling you about in her bedroom. So how do we manage this? We've got to educate and talk to families about this is what's going to happen. So when you get all the family coming around for the big deal at Christmas or whatever it is, you can say to the family and educate them and say, look, Brenda can't deal with too much stuff going on, so actually she's going to be there at the beginning. She's going to go and have a bit of peace and quiet for a while. That's okay. Everybody's fine with that. And maybe if people go and see her one at a time, just have a little conversation, give her a little bit of time to say what she's going to say and to process stuff. Then Brenda could have a really nice time, and we could all have a really nice time. But that takes everybody to admit something's happening that's different. And that's the hard bit, rather than everybody going, right, no, we're all going to sit around the table and pretend nothing's happened, which is the temptation to do it. So education and making allowances and coming to terms with and accepting the person might be acting or thinking in a different way is important. Keep things simple and then wait. With conversations, it can be difficult sometimes because people with HD take a bit longer to process. So I might be like, in clinic, I'll be like, hi, how are you? And then there'll be a little moment where things are a little bit quiet. And you think, oh my gosh, what's happened? And then the person will say, oh, fine. But it might be sometimes quite a bit longer than the average person you might meet in the street. And if you didn't give them that time, you might not get anything out of them because it takes them time enough to think about what to say back. So you've got to give time and wait a bit. If you want chapter and verse on that, there's a lovely book there called Hurry Up and Wait by Jimmy Pollard, which everybody should read. And I'm not on commission, but I do like the person. And I think it's a wonderful book, which all carers should read and people with HD also. So the final bit we're going to talk about is social cognition. That's the ability to understand another person's mental state. or another person's point of view. It's sort of interesting because it's the same bit of brain that looks at what a person's actually literal point of view is. So for instance, this is a thing for the projector. Can anybody imagine what I'm looking at, given that that side is blank? What do you think I can see? The controls, all the buttons, yeah. Good, fantastic. So you're imagining what the world would look like through my eyes, aren't you? Didn't even know you'd done it. But that's quite an important bit of brain clockwork. People with HD find that difficult. And actually that same bit of brain clockwork is involved with you looking at me and being able to imagine how I'm feeling or what I'm thinking about something. So it's the same part of the brain, actually, which is, so literal and metaphorical point of view live in the same bit of the brain, which is fascinating in its own right, really. And people with HD find that difficult, and they sometimes find it difficult to imagine future scenarios. If you put a future scenario to someone with HD, they may well be able to give you some reasoning around it, but if you ask them to generate a future scenario from the get-go, they might find that difficult to do. But if you imagine how much of the time, here's a little experiment. How much of the time do you think you spend in a day thinking about something that might happen in the future? And the future could be a minute from now, or 10 minutes from now, or half an hour from now, or Josh is looking at me, or a year from now. 90% of the time. A lot of the time we spend, and it's useful because it helps you to get off your bum and do things. Yeah. It's hard to live in the moment, isn't it? Actually, it's something that quite a lot of folk with HD find a lot easier to do because they're not bombarded with all those future scenario imagining things, which is hard if you're a carer because it means you have to take on the burden of all that future scenario thing after a while. I think that's what causes these facepalm moments, and I think it's a bit like a late onset Asperger's syndrome. So it's like Asperger's syndrome, which comes on people a bit later. So I think if somebody asks me what's Huntington's disease, it's more like that, really. Right, I'm going to just do one more slide because I can see Saoirse is lurking. So as a result of this problem, the social cognitive problem, it's hard to negotiate with your spouse or your family member, but also you'd get all these other things, including not understanding that there is a problem and also causing a problem for the person who doesn't have HD. So while we're going to manage all that, it's a bit like the other one. We've got to understand the nature of the problem and adapt ourselves accordingly to it, which also means doing some acceptance that things are changing and adapting to that, and managing family communications. So it's a family thing. So that's why I've got this lovely t-shirt. It's a family thing. There's a nice little segue there. Thank you, it's a family thing. So with that, I'm going to stop and say, thank you very much for listening. I'm here all day.